Hi, my name is Ben Young, and I am a periodontist in San Antonio, Texas. And recently I came across, or I was given, a treatment plan. And I'm not saying where it came from, but I'm going to tell you that some of the fees on here are unnecessary, and that basically it's a ripoff. And I hate to say this because it's a reflection of dentistry, but when dentists become employees and they're managed by an entity that is not dental, then one of the possibilities is that the patient care element is not the primary objective of the clinic. The primary objective of the clinic is to make a profit. And they will look for things that they can charge the insurance company. And you might think, oh, well, that doesn't bother me. But yes, it does, because if you have a maximum amount per year that the insurance will cover on your care, you don't want that being siphoned off because you may need that money paying for your care that's legitimate. And secondly, they'll find things to charge you because the insurance company is not going to pay for certain things. So this is going to be sort of lengthy. If you've got my bottom line, buyer beware. You can look at the links, and I'm going to attach some things here that you can go on to. But I'm going to go on to this a little bit and explain some things. So number one, these were charges for periodontal treatment. Number one, if you do not understand what your periodontal disease level is, then you should not be agreeing to going into any other kinds of treatment. The treatment is reflective of the kind and level of disease that you have. And if it just seems like, oh, well, I'm just going to do some, quote, deep cleaning, but then they add all these charges on there, it's probably unnecessary. So in this particular case, the individual was going to be charged for scaling and root planing. That's non-surgical care. It's charged out by insurance codes as either involving 1 to 3 teeth in a quadrant. So your mouth is divided into 4 parts. Upper is cut in half, so you have upper right, upper left, lower left quadrants. So scaling and root planing is either by 1 to 3 teeth in a quadrant or 4+ teeth in a quadrant. In this particular case, we are being charged for the full quadrant amount that the insurance company is going to pay, $259 per quadrant. That's $1,036 for that procedure. Okay. Then on top of it, they're charging for gingival irrigation. Now, gingival irrigation is by quadrant. They're charging $49 per quadrant, so times 4, that's $196, in addition to the scaling and root planing. Now, I have a code book here that says basically that kind of a charge for gingival irrigation is usually picked up by the other code. So in other words, if you're getting scaling and root planing, and they want to irrigate the gums as part of scaling and root planing, then the cost of that should be included in the first code. But in this case, they didn't do that. They just passed it on to the patient at $49 a quadrant. Then in addition to this, they did a fluoride varnish for $52. What's a fluoride varnish? You're getting fluoride in your toothpaste. The varnish is a painting on fluoride that's sticky onto the teeth. For what particular reason? Does this individual have big decay problems? What's the deal? My suspicion is there wasn't anything. It's just an automatic pass-through cost. We're just going to varnish all the teeth with fluoride. And then the next one is an MI paste / dry mouth. I have no idea, but my guess is they gave this individual something, probably a take-home paste, for $35 because they have a dry mouth. I don't know what that is. My suspicion is it's just a pass-through cost of some toothpaste that they're selling. And then they had a take-home medication for lower left. So whatever was going on in the lower left, they needed a medication. They took that home. That's $27. and I'm suspicious that it's probably root sensitivity, tooth sensitivity, who knows, but it's another cost, another $27. But the kicker, local antibiotic, $113 per tooth times 12 teeth, listed out as teeth number 1 through 12. Now, tooth number 1 is a wisdom tooth. Why are we doing this for a wisdom tooth? I have no idea, but it appears to me that they maxed out at 12. They could only charge for 12 for some reason. I have no idea. But what this is a local antibiotic delivered into the pockets. Now, I'll have a link to this to a paper I wrote on the appropriate use of this kind of material. And it isn't for the times of scaling and root planing, even though people have promoted this within dentistry because it is a real moneymaker. So $113 times, which is split up between the insurance company and the patient. The patient is going to pay $60 for each one of these. And I think they have it up to 12 because the insurance company wasn't going to pay more than 12. I don't know why they're paying any of it, and they may not. But this may be a way where they submit it to the insurance company. Whether or not the insurance company pays, they're still going to collect $60 for injection of this material around the gums to the patient, $60 each. All right, that's $720. You're doing a scaling and root planing, which means you're cleaning up the roots and all of that. Why you need to inject an antibiotic. And secondly, here's the real kicker. If you really needed an antibiotic, they could prescribe doxycycline systemically. You could take a few tablets, cost about $20, and it would take care of all of the infections because of an antibiotic, if it were necessary, as opposed to this method. Now, I'm not knocking the use of Arestin or these injectables in appropriate use. They have legitimate, appropriate reasons for use. It's just that this isn't it. All right, so the Arestin thing, I'm going to drop it there because I have material elsewhere you can read about Arestin. You can go on my website, and if you go on my blog, if for some reason we've messed up on the link, you go into my blog on my website, dryoungperiodontics.com. Scroll down, you'll find the blog, click on that, type in Arestin, and it'll pop up as a paper I wrote. And it'll explain to you how Arestin is appropriately used. But the rest of this, I want to just talk about gingival irrigation. And I want to go back to something that was taught once. And it was at a time when I was actually in training. This was a study done in Scandinavia. Now, a lot of good studies coming out of Europe and Scandinavian countries. And a lot of that has to do with they're looking for non-surgical ways of taking care of lots of people. They have a more socialist system of care. And I don't have an opinion I'm going to give you on that right now, except to say that when you're doing research, this is fantastic because you got populations here that you can run these kind of studies on. And some of them are and this one is one of them, very elaborate, very well thought out. And so let's talk about gingival irrigation. First off, what is gingival irrigation? Gingival irrigation is done by a lot of hygienists and others. It's taking some medicament, liquid, and squirting it into the pockets, usually after they've done a cleaning. And then they'll charge a gingival irrigation fee. So the big question is this worth it? What's the results? And have anybody done any studies? Well, as a matter of fact, they have. 1987, I'm going to go through an abstract of this, which is the study. It's a summary of the study, and I hope I can explain it to you in ways that make it useful to you. So number one, they selected 10 patients out of their population that fit the criteria for having periodontal disease with pockets that were advanced and greater. And by my definition, an advanced site is 6 millimeters and deeper. And if you look at my explanation called A Tooth Has 4 Parts on Periodontal Disease, The reason that the 6 millimeter pocket and beyond are significant and important to us is because the populations of organisms that colonize at the base of these pockets are significant, all right? And they turn into anaerobes. All right, so this is an important group. They've selected a good group. Now the next thing they did was they had 3 months of supervised plaque control before they did anything. So they taught people how to clean, how to brush. They supervised it. They watched them for 3 months. And then they went in and they selected the pockets from these people they were going to study. And these pockets were the 6 millimeters and greater, and they were in the 4 quadrants on these people. So now they could do a study where they divided the individuals, these 10 people, up into 4 quadrants. So they have a host individual who is working all of these things as the control, as well as the selected sites where they're going to study it. Here's the point. In terms of studies, you could take 10 people, or take 5 of the 10 and you do run 1 test with them, and the other 5 run another test. And the difficulty will be that well, how do you know that these people over here are the same as these people over here? Well, in this study, it's the same person, and the different areas are going to be irrigated with different things and then studied. Okay. The selection on what quadrant they were going to do what was randomized. They drew straws. They did something to select that. It was not done because one side quadrant had deeper sites or it looked like it would be better for one medicament versus another. It was all randomized. They had 102 sites they were studying. The different irrigations, they did Peridex, which is a mouthwash that's used, that's on prescription. But its use within gum pockets isn't very effective. Lots of studies show that, but that was one of them. The second one was hydrogen peroxide. Don't recommend you use that in your mouth, but hydrogen peroxide is it oxidates, and so it foams and it does things like that. Third quadrant was irrigating with saline. And then the 4th quadrant, nothing at all. So that's your control. And they did 12 visits with this in a couple of weeks, set into 8 months. So the individuals came back. Now, they didn't clean anything at this point. Now I'm going to go back and explain. I'm going to read through this. So irrigation treatment was carried out by the operator 3 times a week during weeks 1 and 2 and 5 and 6 of the trial. And the trial went for 8 months. In the second part of the trial, going from 8 months, that's 32 weeks to 52 weeks, the rest of the year, the sites were subjected first to scaling and root planing. So after the 8 months, they went into these deep pockets and they cleaned them mechanically. And then they also combined this professional irrigation again during weeks 32 through 38. And then remember, it went on to 52. So somewhere they did 6 weeks of irrigation and were on the different quadrants. The previously non-irrigated control site were not subjected to adjunctive irrigation when mechanically debrided. So that meant in the middle, they did the scaling and root planing for the full mouth, all 4 quadrants, but the quadrant that did not get any irrigation was never irrigated ever. Okay, they just did the scaling and root planing. During the entire study, the patients were recalled for professional tooth cleaning once every 4 weeks. So once a month, they came in and they had their teeth professionally cleaned. Re-examinations were carried out at weeks 4, 6, 32, 40, and 52. Re-examination meaning they went back in and they measured all these pockets and they checked for bleeding coming from these pockets. The results revealed that repeated professional irrigation of unscaled periodontal pockets with chlorhexidine or hydrogen peroxide resulted in a temporarily reduced frequency of bleeding sites. That's before the scaling and root planing, but not in any clinically significant changes in probing assessments. So they got So by gingival irrigation without scaling and root planing, they got some reduction in bleeding a little bit, but no changes in pocket depths, nothing else changed. A similar improvement of bleeding scores was observed in the saline irrigation group. Okay, now what does that tell us? Well, it tells us that it didn't have anything to do with the irrigating material, wasn't the chlorhexidine, wasn't the hydrogen peroxide. Saline did the same thing. Well, if we're going to charge you for this special medicament, but saline does the same thing, what are you paying for? There's your point. Scaling and root planing in combination with an optimal supragingival plaque control resulted in a marked resolution of the clinical symptoms of periodontal disease. That's a significant statement and is repeated over and over in periodontal literature, which is simply when you have pockets you cannot reach yourself and they are accomplished, they're clean, scaled and root planed, and you get good oral hygiene to boot, good things happen. Adjunctive irrigation with chlorhexidine and hydrogen peroxide did not improve the healing result above and beyond that obtained after mechanical debridement alone or in combination with the saline irrigation. In other words, the scaling and root planing, which was on that charge, the $259 a quadrant that the insurance company paid most of for that patient. The patient, by the way, paid 20% because it was an 80% to the insurance company, 20% to the patient. The total amount that this patient was going to pay was $1,214. The insurance was going to pay $1,036. The clinic was going to make, what is it? It's roughly around $2,300 on this procedure, on all of this. Way overboard for just scaling and root planing. Anyway, back to this. The scaling and root planing in all four quadrants had the same effect. It didn't matter if it had irrigation or no irrigation. The non-treated site that just had scaling and root planing did as well as every other site. You don't need gingival irrigation. If they're going to do gingival irrigation, and because they're trained to do it or whatever, it should be included within everything else that's done under the procedure itself, whether it's a prophy or scaling and root planing. And if they're not doing that, you need to find another place to go. Let's see. Hence, the study failed to demonstrate that professionally performed periodic subgingival, under the gums, irrigation with chlorhexidine and hydrogen peroxide used alone or in combination with thorough mechanical debridement has a significant therapeutic effect. And it doesn't matter that this was done in 1987. Nothing new has come. There is no better way of doing this. This is the biology of periodontal treatment. And this is why it's important that you go to qualified dentists who will be honest with you and control the cost of these things. Because this in and of itself may not be all an individual needs. Scaling and root planing improved, but it didn't cure. And there are lots of other things that have to be done for patients. So I'm off my soapbox. I'm stopping my rant. Have a great day. If you need our help, contact us. Thanks for watching.